Welcome to Airway Conversations. Dr. Mike DeLuke, board-certified orthodontist, and Nicole Goldfarb, speech-language pathologist and certified orofacial myologist, have joined in this Airway Conversation series to unravel the mysteries of airway health. Together, they'll dive deep into the connections between breathing, sleep, facial development, and overall wellness. Each episode will tackle the questions you've always had, and maybe some you didn't know to ask, about how airway issues impact children and adults alike. Through lively conversations, expert insights, and practical advice, Dr. DeLuke and Nicole will explore topics ranging from early intervention and orthodontics to tongue ties, breathing retraining, and so much more. So whether you're a parent, a healthcare provider, or just curious about the science behind optimal breathing and health, this podcast is your go-to resource. Let's start the conversation.
I have Dr. Mike DeLuke here, orthodontist and host of the Doc podcast. And we thought we're going to do this episode together jointly because we both felt like parents have so many questions about orthodontic techniques, when to start, when to do what. And there's not tons of orthodontists who think from an airway centered or airway aware perspective. And Dr. Mike DeLuke understands airway. He understands total body health and wellness in terms of the cranial, facial, respiratory complex. So how our jaws, the growth of our jaws, the alignment of our teeth affects our breathing, which affects our sleep quality, our health, our well-being, our digestion. And so I think this episode will be really helpful for parents to be able to better understand what they should look for in providers and what type of techniques might be more beneficial for their children. So I'm going to repeat a bio for Dr. Mike DeLuke. And this is repeated from episode 1, so you can just listen again. And I'll talk a little bit about what we talked about in the first episode. And then we'll get into a bunch of questions today. And these questions are questions that a parent might ask an airway-minded orthodontist. So Dr. Mike DeLuke obtained his DDS from SUNY Stony Brook, where he graduated as class valedictorian and was inducted into Omicron Kappa Epsilon. He obtained his certificate of proficiency in orthodontics and a Master of Dental Science degree from the University of Connecticut, serving as chief resident in his final year. Dr. DeLuke is a diplomat of the American Board of Orthodontics, served as the orthodontist on the prestigious cleft craniofacial team at Albany Medical Center, and served as a clinical professor at both Ellis Hospital and the University of Connecticut Health Center Department of Orthodontics, and is currently an adjunct professor at the NSU College of Dental Medicine in the Department of Orthodontics. Dr. DeLuke owned and operated DeLuke Orthodontics in upstate New York from 2005 to 2023 and launched DeLuke Orthodontic Coaching in 2022 with the mission of helping his colleagues succeed both professionally and personally. Dr. DeLuke has lectured at numerous regional and national meetings over the past 20 years, has published articles in multiple orthodontic journals, and sits on the editorial board of OrthoTown magazine. He is also the creator and host of the Doc podcast. So if you're not a subscriber to the Doc podcast, do so right now. Dr. DeLuke and I both Dr. DeLuke, I say to know him is to love him. You are such a great guy.
Thank you.
Your podcast goes over, you interview all these amazing people. And it's funny because we tend to interview the same
I know, right?
We're like totally on the same page. Dr. DeLuke talks from the orthodontic perspective of airway health and well-being, and I talk from the functional myofunctional perspective. And together, I think we really can put together a program that can really help parents and help guide their children. So subscribe to Doc Podcast as well. And in part 1 that we did for my podcast, we talked about the difference between a quote unquote traditional orthodontist and a more airway focused orthodontist. Even though there's no profession that is like airway focused orthodontics, we just talked about what those airway aware orthodontists might be compared to more traditional tooth focused orthodontist. We also talked about why some orthodontists might be resistant to treating or considering airway and whole body. And you talked about, orthodontists might be set in their ways. It's easier to kind of keep your head in the sand. You talked about when you're kind of in your routine, you have your office set up, your program set up. It might not be as profitable when you think in terms of airway, because it takes a lot of time to ask more questions, to do the diagnostics. And you got to be curious, we talked about these things, to really want to step out of that traditional box of thinking. We think from an airway perspective, we want to treat children usually at a younger age. And so that takes that orthodontist being able to understand behaviors and help children who are younger when we're dealing with like longer treatment times, more behavioral issues. And also we talked about how orthodontists tend to not see their patients 20 years down the road, like dentists might or other practitioners, but they might not see the impacts or the effects of their orthodontic treatment in the far distant future. So might not have that curiosity or understanding to think like, how is my patient's health and well-being way down the road when I treated them at a certain age, maybe in teenage years, or 9, 10, 11, 12, 13, what is their health and well-being like when they're 30, 40, 50? Are they suffering from airway and breathing problems? So we talked about phase 1 and phase 2 orthodontic treatment, and we also talked a little bit about extractions. Do those cause airway issues? So check back on episode 1 about that. And we talked a lot, but that's kind of summarizing different content that we talked about. So thank you, Mike, for being here. I really appreciate your time and having this great conversation.
Well, thanks so much for having me back on, and really looking forward to it and excited to collaborate here and get this information out, because as we talked a little bit about in the first show, doing this together, more power we have behind us to just get this message out to a broader audience, which is really, really the goal.
Yes, so great. So I wanted to start out by asking you a little bit about a policy statement and the white paper statement. So the American Dental Association developed a policy statement in 2017 about dentists screening all patients, children and adults, for sleep apnea and sleep disordered breathing. So can you talk about what that is, your thoughts about that policy statement, and does that impact or change the way dentists or orthodontists are currently practicing?
Yeah, I'm glad you want to discuss this, because the ADA, we'll kind of start with that chronologically. It was first in 2017, had a position statement released. And what they really did, which I really like how the ADA approached this, is, and I'm going to try not to get too far down a hole of the definitions of things, because you can kind of dive deep into this rabbit hole of the terms and what we call it. And actually, where we're both presenting at Winds of Change, I will be going into that in more detail and talking about that and when we're during that lecture, because it is important. But to just summarize it, I'll just say that ADA did a really nice job, not just talking about OSA and obstructive sleep apnea, which the sort of rabbit hole is, what is OSA versus what the ADA described as sleep-related breathing disorders, which is anything from snoring to upper airway resistance to actual OSA. So you have this spectrum of issues that the ADA acknowledged. In other words, it's not just a diagnosis of OSA that is what should be the determining factor for whether these children are having issues and comorbidities associated with airway compromise. Okay. Conversely, the ADA, in their position statement in 2019, called their white paper they put out, they went all in. And I think about OSA's mentioned, I believe it's 215 times, something in that arena, and sleep disordered breathing, which is kind of the main, it's often used synonymously with sleep related breathing disorders. So sleep disordered breathing in the AAO white paper was mentioned twice. And those 2 times were only when it was in a reference to a pediatric sleep questionnaire that used sleep disordered breathing. So there's a whole white paper which goes in great detail to the airway, and everyone's using it as sort of the standard that we should be talking about orthodontist involvement in airway, yet they used OSA as the only barometer. And you look through any of the articles in the otolaryngological literature, I mean, there's dozens and dozens that openly say, going back 20 years plus, that the scale of OSA as a determining factor of the patient's suffering from their airway issues is not what we should be making the end all be all. That doesn't mean that there's not validity to OSA as a diagnosis and that exists. What I'm saying is it sensitive enough? Is it detecting these kids who have this airway compromise causing these associated comorbidities, right? And if you look in the medical community literature, they are very clear that it is not, that it goes way beyond OSA. There are a lot of, and ultimately sleep disordered breathing can lead to OSA and obstructive apnea. And Audrey Yoon just had a great paper out in this is now the end of 2024, which highlights a lot of that. Like, our job is to recognize these issues when they're in the precursor stages, sleep disordered breathing, before they get more advanced. But the AAO white paper didn't acknowledge that. The ADA in their position statement in 2017 did. And what they said is basically three things. And I love this. Our job is to recognize that these issues are there, so detect them, work with our medical colleagues as needed for the appropriate solutions, and then perform evidence-based treatment to try to improve the airway compromise. That is a very effective way to approach it, in my opinion, because it distills it down into meaningful steps that the clinician can take. Now, what I'll be talking a lot about at Wins a Change is, how do we even recognize, how do we detect it, right? Like, we don't know, we're not taught this. Orthodontists aren't taught airway. We talked about that in the last episode. We don't know how to look at airway. We're not taught a lot of this. We don't know how to screen for it. So by the ADA saying we should screen for it, that's a great first step. The next step has to be, and one of my goals is to educate colleagues as to what that even looks like. But the AAO in their white paper punted. They actually said, they did say, interestingly, Nicole, the AAO white paper says that the orthodontist should screen all patients for airway and sleep issues. So any orthodontist out there listening who loves to quote the AAO white paper as a reason why orthodontists don't have a role in airway, I hope you're screening every single patient for airway, because if you're not actually following the recommendations of the AAO white paper. But what the AAO white paper does that I don't like and don't feel is scientifically sound is they then say, if you do detect these issues in your patients, right? Let's say you are screening for them and you do detect an airway compromise in children, we're talking about now, your job is to refer it back to your medical colleagues, and then let the medical colleagues be the one that tell you, the orthodontist or the dentist, if the dentist is doing some orthodontics, what to do about this. And so they're punting. They're saying, let the physician be the quarterback. Well, Nicole, it's not the pediatrician's job to tell me if a kid needs expansion or not, right? And for us to shirk that responsibility and make it like, oh, we need the physician to tell us not if we can treat, but quarterback literally the treatment of this patient. When's the last pediatrician you met who knows what orthodontic treatment would be best for a certain age patient? That's not a knock on the pediatrician. That's saying like that's not their job, and they have enough to worry about. They shouldn't have to worry about that. So that's where the AAO wants nothing to do, in my opinion, with this whole airway thing. So they just said, let it be in the hands of the pediatrician. Now, the last thing I'll say is, yes, I understand the pediatrician needs to be the one who diagnoses them with, say, obstructive sleep apnea or even sleep disordered breathing, right? It's not our job to, as a dentist, to make the diagnosis. That being said, we are more than qualified to recognize the signs and symptoms. And if you really want to get nuanced, the diagnosis of sleep disordered breathing is a symptomology-based diagnosis. There's no test for sleep disordered breathing. It's based off medical history and patient symptoms. And that's from the medical literature. So there's a lot of, again, I try to simplify that because it gets very esoteric and random when you start talking about all these terms and definitions. But it's like with anything, the speech matters, and the way what you say and how you define it matters. The ADA in 2017 said we should not only recognize this, but try to do something about it. The AAO in 2019 said we should recognize it, but really just need to defer to the physicians and let them tell us what we should do.
Okay, that's really important to know. And I didn't realize that was a big difference. And so if we're talking about the spectrum of sleep disordered breathing, you mentioned we can have open mouth breathing. Even just mouth breathing is considered sleep disordered breathing. That would be
Hmm.
the lowest end of the spectrum.
Hmm.
There's research that shows that just simply mouth breathing can have impacts on academic performance,
Hmm.
health, and well-being. And then we can work our way up to snoring, which just means there's so much negative pressure. That person's working so hard to breathe, the tissues are actually vibrating.
Hmm.
And then we work our way up to upper airway resistance, where we get arousals in the brain from our poor breathing, our reduced airway size.
Hmm.
And then full blown obstructive sleep apnea, right, would be on that highest end of the spectrum where the airway is completely collapsing, or in a child, there's a certain number of missed breaths per a certain time period, right?
Hmm.
So, the interesting thing that you just talked about is the orthodontic white paper statement doesn't really even talk about those earlier signs and symptoms. And when we
Hmm.
have full blown OSA, obstructive sleep apnea, like that person is not breathing, the airway is closed down, and that child is missing a few breaths. I believe it's like 2 breaths in a breath cycle. Um, they're not addressing any of those lower level deficiencies. And research shows lower forms of sleep disorder breathing, you don't have to have full blown apnea to have similar health impacts, educational impacts, academic impacts,
Hmm.
learning, impacts on inflammation. The systemic inflammation in the entire body is increased when we have any form of sleep disorder breathing.
Hmm.
So if we focus on obstructive sleep apnea, we're missing a huge percentage of children and adults, right, who have this problem. And Dr. Christian Guilleminault, and I know you've talked about this, a lot of people talk about this, who developed the measurement for sleep apnea, the AHI, the apnea-hypopnea index,
Hmm.
wishes he never developed those numbers because it keeps everybody so rigid in not looking at like lesser forms, less or more subtle forms of this significant problem. So maybe a lot of orthodontists really are only focused on the obstructive sleep apnea component and thinking of things in that way, but not
Yeah.
thinking of these more subtle breathing issues that can have the same health impacts. Does that sound right? That it's like that focus is to the extreme?
So well said. It's so well said. I wish my orthodontic colleagues understood it to the level that you just explained it, Nicole. I sincerely mean that. Um, it's, I don't know why we refuse to acknowledge this. It's part of my mission to get out there and educate it, and part of why I'm so glad we're doing this collaboratively, because I can release a lot of this and get this content out there to my ortho colleagues. That's why it's what I'm going to talk about I keep referencing that Winds of Change, but this is my topic that I'm really going to be focusing in on to try to raise this awareness of what you just said. There's numerous studies in the medical literature showing that you do not need to have obstructive sleep apnea, which gets into the apnea-hypopnea index, as you referenced. Apnea's complete cessation of breathing, hypopnea's partial cessation of breathing, lasting for 10 or greater seconds, and then it's averaged per hour. And for various reasons, which go beyond the scope of this conversation, children aren't as likely to have a true apnea or hypopnea of 10 or greater seconds. And that doesn't mean, though, so you could have a kid, just so the parents out there who listen to this can hear this too. Your child might have, I'm just throwing this number out there, 100 episodes of apnea or hypopnea that are 9 seconds. But if they never hit 10, then they're not going to be diagnosed as having an airway problem, because they're not going to be diagnosed with obstructive sleep apnea. Their PSG, their polysomnography test, is going to come back with a 0 for AHI, and they're going to say, oh, this child doesn't have a breathing problem, right? Now, again, we could get into the variability in sleep labs and studies and the issues with PSG and other things that are tested, but the overall take-home message is the literature in orthodontia focuses primarily on OSA. And they look at it and say, well, if this patient had adenoid tonsillectomy and this patient had palatal expansion, at the end, they both started with a apnea, hypopnea, an AHI score of 1.2, and they both ended with 1.2. So it didn't, there's no difference, right, is the conclusion. It is so misleading and incorrect, because again, it's not just about this diagnosis of OSA. And again, if you read the medical literature, they talk about this. And also, to your point about the medical literature talking about the neurocognitive impacts, behavioral impacts, adolescent brain cognitive development study done, published by Isaiah 2021, Nature Communications. What you were saying about children don't have to have OSA. They found that children who snored or even gasped during sleep had significantly smaller volumes of gray matter in their frontal lobes. So that was an MRI study of over 10,000 kids. So we know that this is happening. It's not a mystery, and it's been going on in the medical literature for decades. Yet the orthodontic literature is, in the orthodontists and the orthodontic educational programs are literally turning a blind eye and or putting their heads in the sand on this. And for the life of me, I can't understand why they are refusing to acknowledge the role that we could do to play to help kids. I mean, most professions want to enhance the role that their particular professionals or practitioners can have, right? To show that we're capable of doing more to help. Orthodontics is doing the exact opposite. Orthodontics are doing the exact opposite. We're saying, nope, that's not our area. We can't do anything about it. We just straighten teeth. And again, we talked about that a little more in last episode, but yes, it is. The take home is it is not just about OSA. You can't, not everyone can even get a sleep test. And as I said, the medical literature says that and says that it's not practical for all people and may be inaccurate for many reasons. There's something called the first night effect, which means that most kiddos, if you put them in a lab hooked up to however many electrodes that lab uses and tell them to sleep, you may not get an accurate reading of that child's actual sleep rhythms and sleep cycles, or overall movements, or cardiac output, or oxygen saturation. So they say 2, if not 3 nights successively are necessary. How many sleep labs do you know? And first of all, how many sleep labs are out there? Then how many do you know are keeping a kid for 2 or 3 nights? The parents got to be there with them. I mean, the logistical complications of this, and the medical literature talks about this time and time again, but the orthodontists are just ready to punt it away and say, not our place.
Yeah. And it's so interesting. Like, I have so much to say. Like, this is overwhelming. It's overwhelming for parents. So when we talk about that 10-second or more apnea criteria, where if you're not breathing for 10 seconds or more, so that's like the adult measurement, which supposedly age 18 is when they switch that criteria, right?
Yeah.
So in children,
well, excuse me, the adult, that's the same for both kids and adults, but the number per hour is what's different for kids and adults.
Yeah. So for children, it's having like 2 missed breaths with a certain amount of breathing. Like, it's a totally different number that they're using for children. But a lot of labs are actually using adult guidelines, what you just described, for children. So that's actually a major problem with the way this is being measured as well. But when we have,
and there's no difference in a 6-month-old and a 17-year-old in terms of the scale. They're grading those as the same level. I mean, we know their nervous systems are not the same. We know that their behavioral, overall, how they behave in response to stimuli are not the same neurologically at 6 months old and at 17 years old. Yet we call it children in that entire spectrum. And there's, if you look at the medical literature, they talk about the fact that we have a paucity of normative data, normative sleep data in children. Where is it? Show me the normative data. You know, when we do growth studies in orthodontics, we love to compare to the norms, right? What are the norms? You know, if you want to show over 3 years, you got this growth change, if you go to publish that, they're going to say, well, what was that compared to the norm, right? Because these kids are growing anyway. So you have to say, maybe that change was not, it was significant point A to point B, but maybe if you look at relative to the norms and the normative data and the growth studies we use to compare to, maybe it's not. Where are the normative data for sleep studies? We're just taking a number and labeling these kids, or not labeling them, as the case may be, when they do have other sleep issues, and making all of our diagnostic decisions based on that.
And what I find too for children and adults is sometimes a sleep study will come back as mild, quote unquote, mild. And the recommendation is sometimes watchful waiting. And orthodontist Dr. Derek Mahoney, I always remember this quote because he says, watchful waiting is supervised neglect, right? And what you talk about, normalizing structure. So when someone has sleep disordered breathing, it can be apparent in different different times. So it could be evident while they're sleeping. We could have snoring, noisy breathing, open mouth breathing, tossing and turning, nighttime awakenings, nighttime urination, bedwetting, right? There's a variety of sleep symptoms that could be evident, but there could also be no sleep symptoms evident. And there's daytime symptoms that could be evident. And this is usually what we find often in children is that ADHD, so hyperactivity. Children who are sleep deprived, the majority of cases will become hyperactive in response to that sleep deprivation. Whereas adults, when we're tired, we take naps. You know, I have patients who fall asleep when driving. This is horrible. But for children, I believe it's 92 to 97% of children were actually have evidence of hyperactivity when they're tired, right? Tired and wired. You know, you put your kids to bed like 2 hours later and all of a sudden they're like hyperactive and crazy when they're excessively tired. Other signs and symptoms in children might be issues with organization, learning challenges, memory challenges, moodiness, tantrum, emotional lability. But there's also facial characteristics. And this is where the orthodontist comes in and the orofacial myofunctional therapist, because there are characteristics that are comorbid, so they co-occur with sleep disordered breathing. And let's talk about some of those. I'll say a few of the oral myofunctional characteristics, then you could speak to some of the dental facial characteristics.
Sure.
And this is where our dentists and orthodontists should be looking and screening as well, because it's almost like you can see it, right? You can like physically see when there's a likelihood that they might have poor airway. So from a myofunctional perspective, what we might see is open mouth breathing. Now, we're not always going to have mouth breathers or open mouth breathing in patients with myofunctional disorders, but oftentimes we will. So lips parted. It could be gaping wide open mouth, or it could be slight parting of the lips, but breathing with the mouth open is a problem. Our lips should be sealed, closed, touching when we're breathing, no parting of the lips. So we might see open mouth breathing. Sometimes you'll see like a short upper lip. So the upper lip is kind of pulled upwards or tented. Sometimes the lower lip's everted or kind of flipped out, chapped lips, dry skin around the lips. We might also have low tongue posture. So the tongue is resting down as opposed to on the roof of the mouth. And if the person has an open mouth breathing or their lips are open, you can actually sometimes see the tongue when they're sitting there. That tongue is down and forward or spreading at the sides of the mouth. So that tongue is visible. But if the lips are closed, you can't see the tongue. But it's a myofunctional problem if the tongue's not resting, sucked up on the palate. So low forward or spreading of the tongue at the sides. And we might also have a tongue thrust, and thrust is just to push with force. So a movement pattern of the tongue where it's thrusting forward or thrusting laterally or bilaterally, you know, at both sides. When the person's chewing or swallowing or even speaking, sometimes those are signs of a myofunctional disorder that can be characteristic or go along with someone that might have an airway problem. We might also have oral habits like finger sucking habits, thumb sucking, sucking a finger or two fingers, excessive pacifier use, excessive long-term use of a bottle or sippy cups, or lip licking habits, cheek biting, tongue sucking habits. You might see that lip lickers dermatitis. I just saw that. I want to drop my kids off at school, a couple kids, because it's winter, it's dry out, but why don't we all get these dry marks, red marks, chap marks around the lips?
Right.
Well, some kids excessively lick their lips. So any of these oral habits cause the body to release endorphins that are kind of calming and regulating for the body. And when the tongue is not resting in the correct position, those are the times where people might develop these other habits. When we get the tongue up, resting in the correct position, good breathing with the lips closed, that in and of itself can help calm and regulate the body and promote better sleep. So these habits tend to be negated or non-existent when we have good oral rest posture. So when you see these habits, even like chewing on clothes, sucking on clothing, biting pens and all that, that's often characteristic that there's poor oral rest posture, and that is a myofunctional disorder, is when there's a noxious or a bad oral habit, right? So these are things that are very comorbid with airway and sleep problems. The majority, actually, a myofunctional disorder, everything I just listed, or one of those, it doesn't have to be all those, any of those are characteristic or clinical markers of sleep disordered breathing. A myofunctional disorder is a clinical marker of sleep disordered breathing. I'm going to say the majority of patients I see, whether they know it or not, have poor quality sleep and airway issues. So this is like common for my patients, and a lot of them aren't even aware because that might not be why they're coming to me. So when we talk about signs and symptoms, I just talked about some oral muscular characteristics that might go along with sleep disordered breathing, anywhere on that spectrum of mouth breathing, snoring, upper airway resistance, or sleep apnea. Now, Dr. DeLuc, tell us, what are some dental characteristics that might be comorbid with sleep disordered breathing?
First of all, I really appreciate you going into the detail on that and talking about the myofunctional issues and the fact that myofunctional disorders. And I actually did not know that you could definitively say. I think that's awesome. So thank you for that. That those are clinical markers of sleep disordered breathing when you're seeing those. And the common theme between what you were talking about on the oral myofunctional side and what I'm going to talk about on the malocclusion, craniofacial growth and development side are what we're seeing are the symptoms of the underlying cause. The etiology here is the way they're breathing or not breathing, and as the case may be. And what we're not doing a good enough job in the dental profession, especially I'm critical of my orthodontic colleagues on this, and it's because we don't learn. It's not like I want to be clear. It's not like the orthodontists are willfully, I feel. I think at the top level, administratively, some of our governing organizations, I feel like there is some intent. I have no evidence of that, my opinion, but I feel like it's some intent to kind of keep the orthodontist free of this airway arena. I don't know the motive for that, but I do feel like it has to be somewhat intentional. The average orthodontist out there, or the orthodontic resident, honestly, Nicole, it's lack of exposure. They don't know when they see a patient come in that has those things you just mentioned. And some of them, as immersed in this as I am, I just learned from. I mean, I would see kids with lip licking and all of this, especially when I was practicing in the cold Northeast, and I didn't know that those could be tied to their sleep. So we don't know this. I give the orthodontist practicing out there, a lot of them, I give them a pass on a lot of this because they just aren't exposed to it and don't know it. Our institutions, our educational institutions, and our governing bodies need to do a better job of creating curriculum that educates us as to the importance of this. And the medical literature actually says as much. So that's a separate issue. But what we see when they walk in that we look at and we don't attribute it, rarely do we attribute it to their breathing. So much so that a lot of people in our profession and a lot of thought leaders in our profession oppose the fact that there is any environmental influence on craniofacial growth and development. They say it's all genetic. I've had someone in an online group, online orthodontic only group, say to me, there's a mom and a dad, and that's it. That's the cause of their malocclusion. I mean, I don't know. How do you educate? This is not an unintelligent person. I've seen other posts that they're certainly well educated, but they are dogmatic in that, and they don't even think the environment can play a role. So what they would be saying to you essentially is, well, if that child is obsessively licking their lips or has low tongue posture, whatever, that's genetics. There's nothing environmental. It's almost like they refuse to acknowledge the concept of epigenetics, which is we have genes. It used to kind of be the nature nurture, but in the past that's kind of fallen out of favor, but in terms of the term, but now it's more, we look at it as epigenetics. There's what we're genetically programmed for, and then our environment can impact how those genes are expressed without actually changing the DNA. So that's what we're seeing in the craniofacial growth and development. And our literature has plenty of evidence of this. Harvard had studies on this in the 70s, published through the 70s into the early 80s in the American Journal of Orthodontics, that showed that if you took purebred rhesus monkeys who have no malocclusion at all and plugged their noses with silicone for 6 months, and then another subset for 2 years, they led to those monkeys that had their noses plugged, and so became obligate mouth breathers, had narrower dental arches, more vertical facial growth, more dental crowding, and more severe malocclusions. So we know there's a relationship. Most orthodontists out there would also acknowledge something called adenoid facies. That is an indication of someone whose adenoids are so big, they're blocking the ability of that child to breathe through their nose. So they breathe through their mouth. We know it creates them to have longer face heights, higher palatal vaults, narrower maxillary arches, greater incidence of posterior crossbite, steep mandibular plane angles, the crowding that we see as a result of these narrow arches. So we have evidence of all of this, but we just don't educate ourselves and don't educate our younger docs coming up as to the fact that when we see someone, we learn about this, because I went back actually and looked at a lot of the articles that I read back. I'm old enough that we did this. We had them in paper. We weren't reading them digitally. We had printouts of all these. And when we moved to Florida a few years ago, I had all my files. So I started looking through a lot of it. I couldn't believe how much of this I'd actually read. A lot of this literature on everything I just said with Harvard, and McNamara's got articles on this going back to the 70s, and Linda Aronson. And so I'm like, we read this stuff, but at the end of the day, we learn there's nothing you can do about it. Your job is just to straighten the teeth. And so, yes, we see these signs and symptoms all day, every day, but it seems that my orthodontic colleagues most of them, I'm not saying all, most of them seem to be content with just looking at what they can do to try to put the fire out, instead of looking back and seeing, well, maybe I can get at the cause of this fire so it doesn't spread as aggressively and I'm not constantly chasing to just try to put out the burning flames.
That's what we talked about before. Maybe a traditional orthodontist is more reactive approach, like your
Sure.
teeth are crowded. When you get to be a certain age, 10 or 11, 12, let's straighten your teeth. But proactive would be your teeth are crowded and you're 5 years old. We know this could set you up for poor breathing if you don't already have it, because your jaws are too small to fit all your teeth. Let's proactively help expand, which could help breathing. So many key points here. So one thing I want to say is that I did a presentation at the American Academy of Dental Sleep Medicine in New Orleans this year. The person who went up before me talked about the position statement and went through the different bullet points of the position statement on pediatric sleep apnea, and how they kind of isolated each type of treatment for sleep apnea, whether it's tongue tie release, rapid palatal expansion.
This is the AAO white paper?
No, this is at the American Academy.
I'm sorry, the AADS. I thought they were talking about the AO. This is the AADSM talking about their own release.
Yeah.
Gotcha.
Yes,
Okay.
I guess there was a panel of maybe 15 people.
Yes, I'm
who
aware.
are your pediatric dentists who went through different research studies and came to conclusions on treatment of pediatric sleep apnea from, I guess, like a dentist perspective for the AADSM. And they came up with some summary statements. And they looked at like tongue tie release, palatal expansion.
As monotherapies, what each one did.
That's the thing. Tonsil adenoid removal. I don't think the word monotherapy ever came up. They went through each one, but they were monotherapies.
Yes.
And the conclusion was, this does not work. This does not cure sleep apnea, or undecided. Right. And then I had to go up after that to do my lecture. So my heart's pounding as I'm sitting in the audience. Like, oh my God. Because I'm presenting some of these same research studies.
Yeah.
But when you add myofunctional therapy, or you add other components where it's no longer monotherapy, and we can treat these issues, but these issues are multifactorial.
Yeah, thank you. So, that's the word.
A tongue tie release alone is not going to cure sleep apnea.
Right.
Well, of course.
Right.
Removing tonsils and adenoids is probably one necessary step in the process for many children, but 78% of children, based on Dr. Bhattacharjee's study, 78% are still mouth breathers and still have sleep apnea after you remove the tonsils and adenoids. I witnessed that with my child. I watched
I saw
every
patients
research study
all the time.
Yeah, it doesn't cure, because if you don't teach the muscles how to work. When you take out tonsils and adenoids and the child was a mouth breather, the lips don't just automatically close and tongue goes up, right? Maybe the lips close for a little bit. That did happen to my son for about 3 weeks. And then he started snoring again, because muscles need to be rehabilitated once the medical cause of the mouth breathing is resolved, right? They also looked at rapid palatal expansion. Alone, it might not cure sleep apnea. But when you treat the allergies, you treat the mouth breathing, the myofunctional component, you look at the holistic multifactorial components, we can cure this and we can treat children. But to look at monotherapies and then say we can't help is completely wrong and misleading, I believe.
So
Or it's true, the monotherapy, true, it's not misleading. Yes, the monotherapy doesn't
right.
cure it, but it's misleading, right?
It's completely misleading. And to your point, I've come up against people online who, when I post podcast episodes or articles or make comments on things in the sleep arena and airway arena in the orthodontic study groups, they will literally just put up the 2019 AAO position statement and the 2024 AADSM monotherapies study or position paper that you just referenced. And that they'll say, no further conversation. The evidence says that there's nothing we can do about this. And I mean, I'm not exaggerating, Nicole. That's literally what these people do. And they troll for anyone who mentions Airway on these orthodontic groups. And as soon as it gets mentioned, they start to put those studies up. And I will question them. I've challenged them to debates. I've tried to have conversations with them. They won't do it. And they hide behind this, as you said, misinformation. They're being misinformed. I don't know anyone who's in our circle of sort of the airway aware providers, whatever their particular field is, who says that there's a magic bullet for any of this. Like, oh yeah, make sure. I mean, even as you said, Bhattacharya study from 2010, it made it very clear. Adenotonsillectomy, which has always been the quote unquote gold standard to treat pediatric obstructive sleep apnea and or sleep disordered breathing, that shows the data there show that it is ineffective essentially 3/4 of the time long-term. And I believe the study looked at from 40 days post-surgery to 720 days post-surgery. And they did that because they wanted to try to keep it within a range of when the adenoids would be less likely to try to regrow, which I also could say, well, if the adenoids are regrowing, like what else is going on too, right? Doesn't that give further evidence that there's more comorbidities and more things happening? So yes, it's so much deeper than that. And the only thing I can think is these people, it gets back to what we talked about in the last episode. They don't want to change. Change is hard. And it's just easier because if you really knew that this was something you could have an impact on, I really believe that most, if not all providers go into this, whether they're oral myofunctional therapy, in the speech arena, whether they're in the orthodontic arena, dental arena, pediatric dentistry, sleep physicians, they don't go into this to not help patients. I think most of us, it's a long haul for all of us to go to this extent in our education. And I just don't believe that they're out there thinking, I don't want to believe any of this because I don't want to help people. I think the only thing, it's a defense mechanism. It's just easier to just say, I can't do anything about, AAO says I can't do anything about this. It's the physician's job. It's just easier to do that. You put your head down the pillow at night and think, yeah, I get it. They have an open bite. I get that they have low tongue posture. I get that they have these issues with their craniofacial growth and development, the crowding. But my job as an orthodontist is I can make them look nice, have a nice smile, and fix their teeth. And that's really where it begins and ends. And that's, I like to think that's probably a lot of what's going on.
And we keep talking about like pediatricians and deferring to the pediatrician, but a lot of pediatricians are really unaware of these components of sleep disorder breathing. Like you said, they don't know about orthodontic components. I don't know how many pediatricians know that crowded teeth, narrow palate. Do they even look at the teeth and the palate? But do they even know that those are related? And mouth breathing is related, and tongue tie is related, and all these issues. So deferring to the pediatrician is not the best solution and could actually throw parents off track.
Yeah.
So how many cases have I had, not to talk bad about pediatricians, but it might not, their area of expertise is not the mouth and the oral muscles and the teeth and the jaw bones, right? So I've had cases where parents maybe got a second opinion about tongue tie or something like that to the pediatrician.
Yeah.
And of course they listen to the MD, and then they no longer believe me or pursue my treatment or my thoughts. You know, they can get thrown off track. And
you might ask, what do you do when that happens? How do you handle that? Because I hear that a lot, and that's tough.
Yeah. I mean, I describe that the pediatrician is not trained in oral facial muscles and diagnosing tongue tie. And even the ENT might not be, and even the dentist and the orthodontist, because when we look, if we're talking about like tongue tie, for example, as a myofunctional therapist, we're not just looking at the length of the tissue and the position, but we're looking at how it affects function. So when I said oral rest posture, we're looking at how a lip tie might impact the lip's ability to close, because we're looking at rest posture or functioning. How does a tongue tie impact the tongue's ability to rest in the roof of the mouth in the correct position, or chewing or swallowing or speech? So we're not just looking at how long the tissue is, how
Got
tight
it.
it is, but
Yep.
how does it impact the oral rest posture and the functioning? And I don't think the dentist is looking at that, because why would they? They're not looking at function of oral muscles. A pediatrician isn't, ENT usually isn't. So they might just be looking at range of motion. Can you stick your tongue out?
Right.
Right. So it's different perspectives of where we're coming from. And that could lead to a different diagnosis. So I explain to the parent, and when I refer them to a provider for a tongue tie release, I refer them to a specific person I know who understands function and why the release is important and why it would be beneficial. And if they want to get a second opinion, I do caution them. I give them multiple names of people, but if somebody is not understanding the perspective where I'm coming from, then they might give them a different answer or rationale. So, I mean, we do very detailed measurements for like tongue tie. There's many skills we use and ways we measure. So I do explain that to parents. But I mean, I have had cases. I had one case where there was this young child who they called it like baby talk, the way her speech was.
Yeah, I've heard parents say that. Yeah.
Right. And oftentimes that could be from hyponasal vocal quality. When the adenoids are enlarged, the voice can sound this kind of Mickey Mouse sounding speech, and you can sound like more baby-like speech. But
We
also
see in cleft craniofacial patients, we see that quite a bit.
okay. And so also we know children with sleep disorder breathing, they have a lot more behaviors, less maturity, right? They're more like impulsive, hyperactive. And so this child definitely had a tongue tie. She had enlarged tonsils, enlarged adenoids. We were doing great getting her set up for all these other treatments. Mom even scheduled with ENT for tonsil nano removal, tongue tie release. They're ready to go. Last second, mom's like, I'm going to just get a second opinion from the pediatrician. Went there, and the pediatrician said, you are focusing on the wrong thing. You need to work on her social skills and her maturity, and you are totally in the wrong place. And the mom, she loved me. We got along so great. I love the kid. It was so great. The pediatrician said, you should go see another speech therapist. And they left, and I never saw them again. And I'm telling you, this kid her teeth were so ground down. She barely had any teeth left, because grinding your teeth.
Yeah, that's one I should have mentioned is bruxism. Sure. Yeah. Bruxism and wear for setting.
Sleep bruxism is a sign of sleep disordered breathing. You are clenching and grinding, bringing your jaw forward, bringing that tongue forward to help open up the airway when the breathing is labored. And this child had every sign and symptom, but did not get the treatment because the pediatrician just wasn't aware, didn't understand. And, that only happened once, like something to that extreme, but that's one of those that sticks in your mind.
Yeah.
Like you're like, oh, but what would you say, like, are signs like orthodontic signs, like crowded teeth, narrow palate? What else should parents be kind of thinking about, or orthodontists be thinking about, that might be reflective of airway dysfunction if we're looking at like the oral dental skeletal structures?
Well, it starts even when they first walk in the room, the face. So when you go to an orthodontic residency out there, I can pretty much guarantee for most of them, when they do their problem list creation, they're going to see the patient, put the patient back, and start looking at their mouth first. It's how we're trained, right? We focus on the mouth. And one of the things I teach is we need to look at the face first. There are a lot of things that happen in these patients' faces. Start with their eyes. I mean, a child who is 5, 6, 7 years old should not have tired eyes. And that's, we say it's not really it's somewhat subjective, right? Tired eyes. But we all know what someone's eyes look like when someone's tired, right? Whether it's our own eyes or the eyes of somebody else. So these kids should not have tired eyes. Dark circles under their eyes. Those could be signs of atopy or allergy, which is, we call them allergic shiners a lot of times. And so you'll see kids who have these dark circles under their eyes, kind of these tired, heavy eyelids, dark circles under their eyes, something called Denny Morgan lines, which are wrinkles under their eyes. It's usually like a two-fold, a bifold underneath the eye and the tissue underneath the orbit. And again, you shouldn't see a little kid with wrinkles. Okay. So these are signs a lot of times there's something more going on. Now, it could just be allergies. But if they have such severe allergies, and those allergies are causing their nose to be obstructed through inflaming what are called the turbinates, or the structures in the nasal cavity, if that's wide, just like if adenoids are large or tonsils are large, it's obstructing air going up through the nose, down into the pharynx and down into the lungs. You're having the same sort of effect if it's stopping at the nose. I mean, just think if you pinch your nose together and can't breathe, you got to open your mouth. So where it is along that respiratory tract where this obstruction is. So when you say, well, okay, Mike, but yeah, great. They've got dark circles under their eyes and maybe these Denny Morgan lines or what's called an allergic crease where kids are always like, sniffling and pushing their nose up with the base of their palm. And it creates literally a crease in the nose. Maybe that's a sign that if that's stuffy and congested all the time, they're not breathing through their nose well. So the allergies are related to the sleep disordered breathing many times. There's a lot of studies that bear that out. And we know that the incidence of allergic rhinitis and turbinate hypertrophy, which is the swelling of the tissue inside the nose, is very high right now. There's a high percentage of kids who suffer from that. So when you look at their face and you see, and when I lecture and present, a lot of times I'll show some faces of these kids and it's clear that this child is not thriving. There's a lot going on there. Well, these kids are sleep deprived. They're exhausted. Of course, their face doesn't look rested. And one of the most rewarding things that I do and why I'm so passionate about this, and true story, I just had a mom of someone who follows my content. She found me online. She contacted me. I was able to put her in touch with an orthodontist who I've trained to and help figure this stuff out to get care, and helped her navigate through getting to the allergist and ENT. She just sent me a picture of her daughter. Her daughter's now about 7-8 months into her archwire expansion and with this other provider, and her daughter is a different human. And mom is just like, I can't thank you enough for what you've done for her, how amazing it is. And that, you look at her face before, and it was exactly what we were describing. I think in the picture, her tongue's actually like squirting through her teeth in the front, and she's just got these dark circles and she's exhausted. And then this picture of her kind of posing afterwards with this big smile on her face. And it's like you have a different child. So nothing that mom sent me in those pictures had anything to do with this little girl's teeth at that point. Now you could see her smile was clearly broader and more aesthetic in the second picture, but overall, I didn't know what type of malocclusion she had in either of those pictures, or what was going on as far as her overall measurements on a cephalometric X-ray or a 3D image. But subjectively, I could look at her face and say, this is a different child. So when you see those things, and then getting into what you said, the chapped lips, when they smile, I call them chapped gums. Can you see like these erythematous, hyperplastic, thick gum tissue on these kids when they smile, and it's red and fiery? Well, that happens because it's desiccated and it's drying out, and those intraoral tissues are supposed to be moist. So there's a lot we can see before we ever look in these patients' mouths to start to get a feel for some of what's going on with these kids. And that's a big, important point for parents to understand.
Okay. So this is great. And I want to kind of summarize these characteristics so parents are aware. And sometimes it's just so parents are validated, because usually they're already aware there's a problem and they're like, something's not right with my child, but they need to know that they're usually on the right page. So face first, look at the face first. And this is for practitioners as well. So like what we're both talking about, mouth might be open, mouth breathing, chapped lips, mouth breathers, or just breathing with the mouth open. It doesn't have to be like a panting mouth breather.
Right. Correct. Good point.
Positioning, right? Tongue thrusting, low tongue posture, tongue forward. Look at the eyes, baggy eyes, tired eyes. And sometimes you even see the white part of the eye because the eye is kind of drooping because the facial features haven't grown enough. The bone supporting the eyes haven't grown forward enough. So we kind of see these longer faces. Habits we talked about. Look at the child's profile. We need those jaws to be forward. If we have really recessed jaws, that's very can co-occur with poor airway. Crowded teeth, crooked teeth, narrow palates. So when teeth are crowded, it's because the jaw bones have not grown enough to house of the teeth, right? When we're deficient in our bone growth, we don't have enough space to breathe usually, right? Our palate, roof of the mouth, is the same bone as the floor of the nose. So a narrow palate means there's less space in the nose to breathe. So allergies can even become more apparent because a minor congestion can have more of an impact. But there's a very high correlation between allergies and sleep disorder breathing, high correlation between orthodontic cases and sleep disorder breathing. Bruxism, so clenching or grinding of the teeth, and the dentist or orthodontist might see that dental wear. That's very significant for sleep disorder, breathing or airway issues, and GI issues, reflux, and we talked about behaviors, day and nighttime behaviors, bedwetting, restless sleep, and then all those daytime behaviors. So I think parents probably have a good grasp of like, oh, this sounds like my child, or some of these things sound like my child, and my child's struggling in school. My child is difficult to control the behaviors. I know they have more potential. Something's not right. That's kind of where these things can click for parents. So, what should parents do if they they have a dentist who maybe isn't identifying these things, or they have these concerns, or the orthodontist says, wait to treat until the adult teeth have come in, so we can't do expansion until the 6-year molars have fully erupted, so we just wait. What should a parent do if they're feeling like that doesn't jive with their sense that their child has these issues? What would you say, Dr. DeLuke, for like a parent who is sort of at a loss of what to do next?
This question I get a lot, and it's hard because sadly there aren't enough orthodontists out there who understand this. Part of my mission is to try to get the word out and educate my colleagues on this. And I've had parents say, I've gone to 3 orthodontists, and they all say there's nothing to this. Airway and orthodontics aren't related. It's not uncommon that you're going to take your child to multiple providers and they're all going to say that there's no relationship, or that the way they breathe doesn't affect the face, even though that is a blatantly false statement. Not all orthodontists want to treat younger kids. And that's something we have to, I think, educate parents on, is when we're trained in our training programs, we don't treat younger kids. We talked a little about that in the last episode. We don't treat young kids. And I mean young, like 5 to 7 is a patient that we just hardly ever treat when we're in our training. We treat primarily teenage kids and adults in our training. So they're not comfortable with it. And if they're not comfortable with it, they're not going to recommend it. There's much more time and energy involved in the diagnostic process, the treatment planning process, because then they have to coordinate care with other professionals. They have to work with others who are going to then correspond back with their office, like an allergist and ENT and all my functional therapists. So it's just a lot easier for them to just kind of say, this isn't a thing, and I straighten teeth. Now, for the parents, what do you do about that? Well, resources. I have multiple parents reach out to me and say, do you know anyone in this particular area? And my network has grown pretty considerably in the past couple of years since I've started on this journey specifically. So I don't know someone everywhere, but I know enough people that I'm happy to try to, if I don't know someone in that area, ask someone I do know in that area, if they know someone in that area, and see how we can try to find them some help. Don't settle until you get the answers that you feel you need. You know best as a parent. Your instincts are right. Nicole, I can't tell you how many times that I would go through this diagnostic process in my consultations. And as I'm going through it, and we didn't get into as much, but there's other things for screening, like you can do a sleep questionnaire. But even if you don't do a formal sleep questionnaire, you can still look at the signs and symptoms of sleep-related breathing disorders. And I mean, I didn't use a sleep questionnaire for the first many years of doing this because I didn't know enough about it. I just started asking the questions. So it's important you know what questions as a provider to ask these parents. So parents, if they're not asking you about your child's sleep habits, if they're not asking you about if you've seen an allergist, seen an ENT, if they're a nasal breather or a mouth breather, if they're not asking you these basic questions as part of their standard intake forms, then that provider is not practicing in lines with the guidelines of the ADA, American Dental Association, or the AAO, American Association of Orthodontics, which both call on us to do that, as is the American Association of Pediatric Dentistry. So if they're not asking about airway, then that means they're not following the guidelines that are out there. Now, whether they can treat it or not, meaning treat the signs and symptoms or address that earlier. So as we were talking about, we don't treat airway. I'm big on saying it's not like I treat their airway. I normalize the craniofacial anatomy the way I know how based on my abilities and expertise, and work with my medical colleagues to help address their areas. If I'm not comfortable with that, but I should still be screening for it, but I should be saying, look, your child's 6. I'm not really comfortable at this point doing anything. I don't treat a lot of this age patient. We need to be big enough as providers to be able to refer that patient and find someone who does refer that patient to someone who does deal with that, and realize it's not about keeping that patient our patient. Because in the orthodontic profession, we don't want to lose that patient. We don't want them to go somewhere else. So we'll tell them, oh, I'll keep checking them. I'll watch. Maybe they'll outgrow it. Hence the supervised neglect of Derek Mahoney that I love, of the watchful waiting. So if they're getting that sort of runaround from a provider of, well, maybe they'll outgrow it, or maybe we should pull some teeth to solve the crowding. Please show me the studies, anyone out there, that shows that crowding in 6-year-olds is due to macrodontia. I'm still waiting. I've yet to see that evidence. So there are multiple studies that show the opposite, that crowding is not due to large teeth. It's due to narrow jaws, as you referenced. So if they're trying to take those measures in these patients, so not paying any attention to airway, not asking basic questions about sleep, breathing, tonsils, adenoids, allergies, nasal congestion, if that's not part of their process in their evaluation, and then if they are finding some of this out, but they're then saying there's nothing I can do about it, that's a pretty good sign you're with somebody who doesn't understand what they're supposed to be doing to uphold the professional standards that we're being called upon to provide to our patients. We could have a whole different debate on what we can do about it, right? That's actually a whole separate conversation, whether you start at this age or what you start and when you start. That's a whole separate discussion, which I think we should revisit as we going through this journey, you and I together, of bringing these points up, because that takes a lot more time. But at the very least, they need to be doing those things. So I also want to make it very clear, and we talked a little bit about this before too, not everything's an airway problem. Just because they have some crowding, just because they're growing vertically, it doesn't mean they can't breathe. It may, but it doesn't always. And so you have to have the skill set to be able to understand what is related to airway and what isn't. You can't just go sending every patient who has crowding to the ENT to look at their nostrils or adenoids. I had a 3D imaging machine, so I could see that myself, but you have to know what to look for in these patients. So not everyone who has dark circles under their eyes has an airway problem. Maybe this child has a disturbed home life and they are bouncing back between mom and dad's house in a divorce situation and they barely ever sleep. So there's other things that could be going on. The point is you have to be, your provider should be asking these questions and then trying to find solutions that don't just revolve around straightening teeth, and that revolve around trying to get the patient to the best overall health possible.
That's a really good point. And I see there's a lot of dentists who are now doing orthodontics. So
Yes.
maybe actually back up and tell us, what is the difference in training for an orthodontist versus a dentist? Is it just additional like residency specialty? Like what is that difference? Because I'm not exactly aware. And then how is that some dentists can do orthodontic type treatment? And what does that mean?
That's a great question. Actually, ironically, talk about things come full circle in life. This is my master's research was on this topic a couple decades ago. But so a dentist, all orthodontists are dentists. So we've all gone through dental school. Dental school is 4 years after your college years. So we've all gone to dental school. We've all graduated from dental school and all are licensed as dentists. There's no, most states don't license the specialty. They license the dentist. And then you get a certificate in that residency program, additional education beyond dental school to practice your specialty, whether it's orthodontics or endodontics or pediatric dentistry. So most orthodontic specialty programs are 2 to 3 years. And a lot of them, as mine was at UConn, you also get a master's. Mine was a master's of dental science that I got as part of that. You have to do research, master's level research. So that's the difference in training. And now what does that 2-3 years involve? It involves focusing solely on the orthodontic side of patient care. So you're no longer doing fillings and crowns and dentures and all of that. You're literally focusing only on orthodontia. You're doing extensive literature reviews. You're retaking head and neck anatomy in most of these courses or most of these training programs. And then you're starting patient care. You're starting to treat patients orthodontically. You don't get hardly any orthodontic education in dental school. So it's very unique that way. You get training in it. You're pulling teeth in dental school as just any dental student. You have to pull a certain number of teeth. You have to do a certain number of crowns. You have to treat a certain number of kids in pediatric clinic for pediatric dentistry. You have to do a certain number of root canals. You don't have to do orthodontia really at all. Most dental schools, you bend a little wire like in a lab. I mean, you're not really doing anything orthodontically. So dentists come out with very limited knowledge in orthodontics. That being said, many dentists and pediatric dentists, general dentists, pediatric dentists, are seeing the orthodontists not engaging on this issue, not being willing to help these patients, as we've just spent the last period of time here talking about. And they are pursuing the education themselves from a continuing education perspective. A lot of the doctors I train a lot of orthodontists, but I also train a lot of general dentists and pediatric dentists. My orthodontic colleagues get upset about that, and they're bothered. They're bothered by that. And my answer is, I know plenty of general dentists and pediatric dentists who, if they've pursued the right training, I've had many on my podcast, they have way more airway knowledge than many orthodontists that I know. And they are doing far better job of dealing with the issues we've been talking about than my orthodontic colleagues. So my point is, if you're educated and knowledgeable on this, it doesn't matter whether you have orthodontist after your name. There's a lot of ego involved, and the orthodontists are kind of like, this is our territory. Well, most of the general dentists and pediatric dentists with whom I speak, Nicole, they don't really want to be doing a lot of this. They, Dr. Lipkin and I, Ilya Lipkin and I, he was on, I know he's on your show as well. We discussed the fact that most of the non-orthodontists aren't really thrilled about having to do this. They actually have some anger and resentment towards the orthodontist for the fact that they have to, because they've got busy practices. And this whole myth that I've noticed in this arena, that with coaching and training, all different providers, all different types of dental professionals, specialists and non-specialists, is a lot of them, I always thought, well, these non-orthodontists are doing ortho just to try to make more money, because orthodontics tends to be more profitable. Most of them with whom I speak, they took a pay cut to start to do a lot of this airway-focused orthodontia. They had to stop doing a lot of what they were very good at and was lucrative for them in their general dental practices or their pediatric practices. So I don't believe anymore that money is the primary motivator for this. I feel it's the desire to help patients. And so
once you see something, you can't unsee it, right? We always hear that saying.
Right.
And there's a lot of airway dentistry type courses out there for continuing ed. And the dentists who are taking these courses, they're the curious, people. They're seeing these patients twice a year. If you go in every 6 months for a dental visit, and some of them are asking the right questions, seeing the signs and symptoms. And once you go down that route, you can't turn back. When you see a problem, you can't ignore it. And so I think that's where it is they're like, I can't ignore this. I have to do something about it. Perhaps some orthodontists aren't seeing it to begin with. So that's part of the problem. Sorry to cut you off, but I just thought, that's a great thought is once you see something, they can't unsee it.
You're 100% right. And I'll add to that, a lot of it was the first time they saw it was their own kids. I hear that time and time again from the non-orthos and even the orthos that I coach and train. I was like, I didn't believe this. I didn't believe in this until it was my own kid. And, that, for whatever, for better or for worse, that is how we are wired, right? When we see sometimes it doesn't hit home with us literally until we see it in our own family members. And then it puts us on a little bit different of a journey.
Yeah. Wow. This was so great. And I'm hoping this helped a lot of parents answer a lot of some of their questions, whether they're basic questions, or maybe this really helped them feel validated, or maybe they have more questions, but I do. We don't have time, but I have a whole list. So I'm going to just say some topic points that you and I are going to talk about as we do this parent series.
Perfect.
And we'll address this, and we'll keep addressing whatever questions people and parents may have. But some things that we're going to talk about is what happens if the orthodontist wants to, or the dentist wants to pull some teeth. Pull bicuspids.
Great.
What do you do? What are your thoughts? We're going to talk about that in a different episode. What if my child's had expansion when they were 5 or 6 years old? And are they going to need more orthodontic treatment when they're older? Is that normal, or is it just one and done type thing? Is wisdom tooth extraction a problem? What about retractive techniques like headgear? Is a headgear always a problem? How do I know if my orthodontist is using a retractive technique? And retractive meaning pushing things back, which can impede on the airway. What techniques might an airway aware orthodontist use versus maybe a traditional orthodontist? What are some different appliances? And how should I, as a parent, talk to my orthodontist when I want a more airway type approach? And do I just try to convince them, or do I go somewhere else? What do I do? How about expanding? So when a child has a crossbite, we'll talk about what that is. Orthodontists are usually keen to expand the palate, which makes sense. But what about when there's no crossbite? So the upper teeth are outside the lower teeth and normal like bite, but the roof of the mouth looks narrow. Is it okay to still expand in those cases?
Got a lot to say about that.
Yes. Right, we can't let that go. Yes, it is. You don't need a dental crossbite to expand. But also, how can parents and professionals find airway aware orthodontists and dentists? You'll talk about that in a different episode. I'm curious, you teach a lot of orthodontic residents. Are they more open-minded? Maybe they're younger, newer to the field, and are maybe more open-minded versus somebody who's been practicing for a while. And what other questions? Let's see. I have so many questions that we could talk about. If the child only breathes with the mouth open when they're sleeping, is that a problem? Yes, it is, but we'll talk about it later. What about the orthodontist wants to put tongue crib, spikes, rake, because the child has a finger sucking habit or tongue thrust habit? Is that okay? We're going to talk about that and why that's not okay. In many cases. So we have a lot that we're going to continue to cover. And as more questions come up from parents or professionals, we're going to attack them. But we've been an hour and 10 minutes, so I don't want to take more of your time. Thank you.
Well, thank you.
Dr. DeLuke.
I'm so excited to do this. It is so much fun, and it's great. I give you so much credit, as I mentioned before, for being on this journey with me and with those of us who are fighting this fight. And this is what we have to do. And I'm happy to do this. And we each have our platforms. We can put this out. We can expose so many people. And I'm excited just to share a lot of this. I know this is a lot of it's designed for parents, but I'm excited to share this with a lot of my orthodontic colleagues, because I get a lot of these questions from young docs and orthodontists, the very questions you're asking, and they don't know what to do if they haven't learned a lot of this, and they don't know what to look for. So this is going to not only help the parents to understand better for their children, but it's going to help the doctors better understand. And we really need that two-pronged approach to this. It really is. The families have to understand what's going on to ask the right questions, and then the providers have to do their job to be able to help them. And I'm really excited to be doing this with you.
And other airway professionals. So orofacial myofunctional therapists whose patients are asking them these same questions. Like, this is a platform where we can help answer these questions from someone who's experienced as you in this airway field, who understands the structural component of this, breathing and whole health, and where I can explain the functional and the muscular component and helping to put it all together. So this is great. We will we'll talk again soon for the next episode. So thank you so much and have a good rest of your day.
Thanks so much, Nicole. You too. Appreciate it.
Thank you. Thank you so much for joining us for this episode of Airway Conversations. Dr. DeLuke and I greatly appreciate you taking time out of your day to be with us for this episode. If you have any questions, feel free to email me at nicole@airwayanswers.info, and please subscribe to both of our podcasts for the next episode. My podcast is Airway Answers with Nicole Goldfarb, and Dr. DeLuke's podcast is the Doc Podcast. Thank you so much, and see you at the next one.